Yeah, I think for the mood disorders, we can quickly go through the charts.
Okay. Okay. So differential diagnosis of depressed mood, first of all, is the major depressive disorder. We studied that the mood basically change should be present for greater than 2 weeks, greater than five of the nine symptoms, depressed mood, and the CG-CAPS, the PSI-CAPS, or I generally pronounce like PSI-CAPS.
Yeah.
Significant functional impairment, no lifetime history of mania. There shouldn't be any history of the mania. Persistent depressive disorder dysthymia, that is for the longer time, 2 years. Chronic depressed mood is present for greater than 2 years. Two of the following symptoms are present at least, like appetite disturbance, sleep disturbance, low energy, low self esteem, poor concentration, or the hopelessness.
So in the dysthymia, it is like two
Longer
years
duration,
and
like
then
for,
two symptoms.
yeah, same like cyclothymia, that is also present for greater than two
Two.
years.
Yeah.
Yeah. Adjustment disorder with a depressed mood. So onset within 3 months of identifiable stress. So there will be a stress and then the symptoms will be present within the 3 months.
3 months.
Marked distress or functional impairment does not meet the criteria for any other medical DSM-5 disorder. So, what is the normal stress response that is not excessive or out of the proportion to specific or to the severity of the stressor and does not cause the significant functional impairment? So PSI-CAPS, should I read it? Like S for sleep disturbance, I loss of interest, excessive guilt for G, E for low energy, C impaired concentration, A appetite disturbance, P psychomotor agitation or retardation, and S suicidal ideation. So we did this
We
on a
did this
major
kind of.
depressive. Yeah, okay.
Uh,
Acute mania. We read acute mania, yeah. So
yeah.
acute mania, the clinical feature is elevated irritable labile mood, increased energy activity, decreased need for speech, pressured speech, racing thought, distractibility, grandiosity, risky behavior, marked impairment, may have psychotic symptom also like hallucination or delusion or distort thought behavior. Management is antipsychotic first and the second generation, lithium avoided in renal disease, valproate avoided in liver disease. Combination in severe mania is antipsychotic plus lithium or valproate. Adjunctive benzodiazepine for insomnia or agitation.
So
So
basically, for acute mania, we are giving
yeah,
antipsychotics first.
antipsychotic always, or we can use the lithium, but we should avoid in renal disorder, and valproate we should avoid in liver disorder.
Liver.
Yeah. So manic episode, this is at least greater than 1 week of elevated or irritable mood and increased energy. At least like 1 week, along with three of the any of the features should be present. Four if mood is irritable only. If the mood is changed, so at least three plus one is like four. Dig fast, that is distractibility, loss of impulsivity, risky behavior, grandiosity, flight of ideas, racing thoughts, increased activity, psychomotor agitation, decreased need of sleep, talkativeness, and pressured speech. Severity is impaired psychosocial functioning, may have psychotic feature like hallucination or the delusion, and it may require the hospitalization. Okay, bipolar and the related disorder, manic episode or hypomanic episode. First, the manic episode, the symptoms more severe, 1 week unless hospitalized. It causes marked impairment in social or occupational functioning or hospitalization necessary. May have psychotic feature, makes episode mania manic by definition. So, what is the hypomania? The symptoms are less severe than manic. It is present for greater than 4 consecutive days. For manic, it should be at least for 1 week, but in hypomania, it should be for greater than 4 days. Unequivocal observable change in functioning for patient baseline. Symptoms not severe enough to cause a marked impairment or necessitate hospitalization. For in manic, we there is a marked impairment and we need the hospitalization. But in hypomania, it's not so severe that it is causing the marked impairment, and we do not need the hospitalization.
Mm-hmm.
So no psychotic feature in hypomania, though in mania they were present. Some of them.
Mm-hmm.
Many of them, sorry. Bipolar, one is diagnosed when we have only manic episode. So depressive episode is common but not required for diagnosis. Okay. Now for bipolar 2, hypomania episode and greater than one major depressive episode should be present to diagnose bipolar type 2. Cyclothymic disorder, again, it's like same like depressive disorder, greater than 2 years of fluctuating mild hypomania and depressive symptom that do not meet the criteria for hypomania or major depressive episode. Okay. um, Mood disorder with a psychotic feature versus primary psychotic disorder, major depressive or bipolar disorder with a psychotic feature. So psychotic symptoms occur exclusively during mood episodes. Whenever there is a mood change, the psychotic symptoms will be present. Schizophrenia is mood symptom if present are brief and not prominent. In schizophrenia, the mood symptom is present, but it is not prominent. Schizophrenia mood symptom occur exclusively during mood episode.
Sorry, you can't hear you.
Okay. Major depressive or bipolar disorder with a psychotic feature, psychotic symptom occur exclusively during mood episode. Schizophrenia mood symptom, if present, are brief and not prominent. Schizoaffective disorder, major depressive or manic episode occur concurrent with symptom of schizophrenia. Lifetime history of delusion or hallucination for greater than 2 weeks outside of mood episode is present. Mood episode are prominent and recur throughout the illness.